तो क्या करें? तो अगर वैस्कुलर इंजरी है तो सबसे बड़ी समस्या जो होती है, द बिगेस्ट प्रॉब्लम विद अ वैस्कुलर इंजरी इज हेमरेज एंड शॉक. And that is another subject. We'll deal with hemorrhage and shock separately. But the second important problem with a vascular injury is loss of blood supply. So any injury, it is mandatory to look at signs of lack of vascularity. And they are pallor, pulselessness, paresthesia, paralysis, and pain, which we call as ischemic pain. The important thing is not only should you look at them before you start the management, but also during and after you have managed. That is important. You've done a fantastic reduction, you've given a plaster, and if you forget to do this, you'll lose the limb. So supposing there is a vascular injury and you have found out that the blood supply is less, these signs are there, these symptoms are there. So one rule that can tell you, one physical sign that can tell you that there is vascular insufficiency is what is called as the 2-second rule. If this is the nail, you press the nail, normally it will take 2 seconds to fill. Within 2 seconds it should fill. The nail should fill within 2 seconds. If it takes more time than 2 seconds to refill, it means there is a lack of vascular supply. Another way to quantify vascular insufficiency is put in a pulse oximeter. The third thing is look at temperature. A cold limb is a ischemic limb. The fourth thing is if there is edema in a closed compartment, you have to rule out vascular insufficiency, or you have to say vascular insufficiency unless and until proved otherwise. This is what you do in compartmental syndromes. So more suspicious you are, safer you are as a doctor. So when you detect this vascular insufficiency, what do you do? The first thing you do is remove all bandages, plasters, splints, and relieve the limb of any external pressure. The second thing that you do is you at least grossly reduce the fracture by giving traction on the limb. The third thing is, if a joint is flexed, extend it. For example, if you flex your joint like this, all of you will notice that the radial pulse goes. You can see it, test it. Therefore, you decrease the flexion. कस के दबाओ, कस के फ्लेक्स करो, गायब हो जाएगी. हो गई? हाँ? Supracondylar fracture reduced किया. You have reduced a supracondylar fracture. Hyperflex the elbow, the radial pulse will go. So always remember that a joint position can cause vascular insufficiency. The fourth thing is elevation decreases the blood supply. Keeping the limb below the level of the heart would increase the arterial blood supply or perfusion pressure in the limb. The next thing is anemia would aggravate vascular insufficiency, shock would aggravate vascular insufficiency. So what you are seeing as a vascular insufficiency or pulselessness before you have treated shock may become normal as the blood pressure comes back. Then what is causing the vascular insufficiency? Whatever is the cause is either in the lumen or in the wall or outside the wall. I have told you many causes outside the wall, but one of the important causes is compartmental syndrome or edema of soft tissue in a closed space. You have to remember this diagram. This is the tibia. Its posterior surface is divided by a border, and here you have the fibula. Its border is also divided by this. Between these two, you have the interosseous membrane. You have another membrane which connects this and this, and another membrane that connects this and this, and a third membrane that connects this. Therefore, in the leg, there are 4 compartments. The anterior, the peroneal, the posterior, peroneus longus brevis, the posterior, superficial, containing the gastrocnemius and the soleus, and the postero deep, containing the tibialis posterior. And you would appreciate that if you remove this fibula, all compartments are going to get decompressed. Besides this, there can be pressure on the vessel in the cervical rib situation or scalnus anticus syndrome. There can be pressure if you have tied a figure of 8 bandage here. There can be pressure on the vessel as it passes below the bicipital aponeurosis. Below the biceps gets inserted into the radial tuberosity, has a bicipital aponeurosis, and the brachial artery and median nerve pass below it. There can be a pressure as the vessels dip below the flexor digitorum superficialis tendon. There can be a pressure on the blood vessels as they lie deep to flexor digitorum superficialis between flexor pollicis longus and flexor digitorum profundus. Alright. Another way to find out differentially whether the ulnar supply or the radial supply is intact or not is a test by which you close your palm like this and you press both the ulnar and the radial. When you open it, the palm is pale. You leave the radial and see the circulation return back. Do it again. This time you leave the open it and leave the ulna and see the circulation return again. So differentially you can tell whether both arteries are functioning or not. This test is called as Allen's test. Okay. So these are the various tests by which you evaluate. Then you also find out what is the duration of the vascular insufficiency. You must record it in your case sheet as to what is the duration of the vascular insufficiency. Because if you restore circulation after 6 hours, then the myoglobulin can travel into the bloodstream and can cause renal failure. So you'll have to be careful of that. So now, supposing in a wound you find that the vessel is sectioned and you can see both ends, and for at least some time the vascularity will be preserved. After all these measures, you reassess, and if the circulation has not returned, then you explore the blood vessel. You trace it till the pulsations are there. And from the point where pulsations disappear, you find out whether there is pressure outside or there is spasm or there is a clot or a thrombus or an embolus inside. If there is spasm, you put xylocaine, and xylocaine relaxes the sympathetic supply. You can also do a stellate ganglion block in the upper lip or a sympathetic block for the lower lip, and you come to know that the stellate ganglion block is successful by the Horner syndrome, which means ptosis, meiosis, and hydrosis, flushing of face and ophthalmos. Then you can simply do a proximal arterectomy and resuture the vessel to relieve the spasm. If the spasm is not still relieved, you can resect the spastic segment, mobilize the ends and resuture, or put in a reverse vein graft. For a thrombus or an embolus, you put in a Fogarty's catheter and you do an arteriotomy, you put in a Fogarty's catheter and you remove the embolus and the thrombus. After the circulation is restored, you hyperonize the distal part of the extremity so that the circulation is maintained. So this is how you deal with vascular insufficiency. Now would Saurabh want to tell anything else besides this? How to deal with vascular insufficiency? कुछ और बताना चाहो तो बता दो. Huh? You dealt with the subject? Okay. Saurabh doesn't want to tell anything?